Now, here to sit down and talk with us about the genitourinary cancer abstracts being presented at the 2018 ESMO Congress is Dr. Daniel George, who is Professor of Medicine and Surgery at Duke Cancer Institute. Hi, Dr. George.
Hi, Tina.
Thank you for being here.
My pleasure.
Great.
Yeah.
So let's talk about some of the kidney cancer abstracts being presented at ESMO first, especially the Javelin Renal 101 trial. What are we looking at with that study?
Yeah, really exciting times right now in renal cell carcinoma. The front line has been changing in the last year. We've seen cabozantinib move into that space, nivolumab, ipilimumab move into that space, particularly in patients with intermediate and poor risk disease. Now we have data from Javelin 101 of avelumab plus axitinib, two agents kind of new to the frontline space that have shown superiority over sunitinib in all comers. PD-L1 positive and negative, good risk, poor risk, didn't matter. We see all comers significant improvement in both progression-free survival and in response rate. So very exciting to see that data come out now. I think a real practice-changing option for patients in that frontline space. If and when we see an approval for that.
Definitely, great point. Now, moving into prostate cancer, we also saw a little bit of data with Stampede, and you have posters with S-Track as well. So do you want to share a little bit about that?
Yeah, sure. So the S-Track stuff, still renal cell carcinoma, looking in the adjuvant setting, again at this really, first ever adjuvant approved therapy for high-risk renal cell carcinoma, sunitinib study showing a 24% reduction in disease-free survival, but no effect on OS. So what we've been looking at now is what is the relationship between disease-free survival and OS. We've done a number of really strong statistical analyses to look at this, both for the Sutent arm and for the placebo arm, and what we can say is there's at least moderate relationship between a delay in disease-free survival and overall survival. What we need is a meta-analysis. We need more cases, more outcomes, and more settings. So we're going to be partnering with the ASSURE study, and hopefully the PROTECT study begin to look at that. But this is really our first look from S-Track to say that, yeah, there really is a relationship, and disease-free survival is important in adjuvant renal cell carcinoma. Now, switching to prostate cancer, really, really interesting results, again from Stampede. This study just continues to show us and educate us, practice-informing data. So, again, these are metastatic hormone-sensitive patients treated with now the standard of care, androgen deprivation therapy and docetaxel. And this particular arm looked at the combination with consolidative radiation therapy or surgery, but primarily radiation therapy on the prostate after that treatment with chemotherapy. And lo and behold, there's an improvement in both progression-free survival and overall survival associated with that localized therapy in the patients that have limited metastatic disease, 3 metastases or less. As soon as you go into more extensive metastatic burden, we see that benefit go away, which really tells me that there's a biologic difference between these patients with limited metastatic disease. They're more like our high-risk localized BOLA type patients, and the patients with more extensive disease are really the patients that we need kind of all hands-on-deck systemic therapies. So to me, it's really helping us define the differences in this population, but the value still of localized consolidative therapy. Now, I think, our standard of care practice for that population.
Great. All right, and now let's look at some other ongoing trials that are in this space. What do you think has the potential to also be practice changing? What's really exciting?
Well, I think there's going to be more from Stampede, and the PEACE trial is also looking at additional layering in different settings. So I think now we're seeing more and more from these larger consortium studies that just keep going on and on. When we think about renal cell carcinoma, now we're going to see, the readout in the next few months from the pembrolizumab axitinib data and how that looks compared to Javelin 101. And then I think there's also going to be some data in the second line space. And I think second line now needs to be redefined because we have new frontline therapy. It's really combination therapy. What do you do for a patient that's been on multiple agents in the frontline setting? So we're starting to see some studies looking at TKIs like cabozantinib combined with other novel agents, and a glutaminase inhibitor, CB839 from Calithera, is an exciting one. Really interesting biology. We know metabolism is really important to clear cell carcinoma. So how that plays out in combination, can we see a real delay in progression-free survival, improvement in progression-free survival with that? I think really remains to be seen. But exciting data to see that come, and we really want to see that trial accrue as well.
There's a lot going on.
A lot going on in this space.
So now let's reflect on everything that we're learning about here at the ESMO Congress. What does this really say about the future of GU cancer treatment?
Well, you know, Gina, I think this field is moving faster than ever. I think more and more you're seeing, and across oncology, the need for people to kind of subspecialize to really keep up with what's going on. And I think that's going to be the case in GU cancers as well. We didn't even talk about bladder cancer, but there's more going on in that space as well. And so getting people, whether they be academic or community, to really concentrate in GU. We've got people that concentrate in bladder and people concentrate in lung. There are a lot of community people that do GU cancers. We need to now really build a consortium and engagement around that. We're going to need more patients than ever for the increasing number of trials that we have. And we're going to need more multidisciplinary trials. We're going to see more therapies enter this early disease state, whether that be adjuvant, whether that be first line, whether that be in combination or in sequence with surgery or radiation. We're going to need, whether it's renal, bladder, or prostate, that kind of multidisciplinary approach. So really exciting times, but I think really kind of changing paradigms for the field.
It's very exciting. Thank you so much for sitting down and talking with us about all of that today.
My pleasure.
Great. Thank you.
Thanks.